All right, moving right along, we're in chapter 16 and we're going to cover history taking. And they say that getting a really good history is about 85% of your diagnosis, and I truly believe that. Using something like sample, and we're going to expand upon that a little bit, things like OPQRST, we're going to expand upon that a little bit, you pretty much can figure out what's going on with your patient. So what we hope to accomplish in this particular lecture is to describe the structure and the purpose of a medical history. We'll list the components of a comprehensive history for the adult patients. We'll describe how to obtain a comprehensive health history. We'll list unique components of a comprehensive history for pediatric patients and how they differ when getting histories on pediatric patients compared to adults. We'll gather those are our objectives. This is a rather short chapter. So starting with the first slide in the chapter, the purpose of getting a medical history is to gather data. And we've been taught all along to use sample, and we're going to add an R onto the end of that and call it sampler, and I'll explain what the R is here in a bit. The other reason for getting a history is to establish the reliability of the patient as a historian. If during the gathering of your history your patient isn't alert, awake, and oriented, and they might be under the influence, you really have to question how reliable are their answers. Also, the purpose of getting medical history is to monitor your patient's progress, see if they're actually getting better or worse. It also allows you to establish a rapport with the patient, particularly in how you obtain the history. If you're patient and you've got good eye contact at their level and you allow time for answers, you can establish a rapport with the patient, and they're more likely then to give you additional information. And then gathering patient education to prevent future illness or injury. A teachable moment may come out of getting a medical history. We have to be careful with those, but certainly there are times where, we could use the information that we gather to illustrate a point to the patient that may prevent that illness or injury next time from occurring. In obtaining a comprehensive health history, your ability to communicate is essential. I mean, obviously you're going to be asking questions and you're going to be hoping to get answers concerning those questions. So you have to have effective communication skills. You have to be able to, again, look the patient in the eye and with a calm, soothing voice, be able to ask them appropriate questions. Now, there's three main goals of obtaining a history, and we've kind of touched upon them as well already. One of the goals is to establish patient rapport. The other is to obtain data so that you can help assimilate a differential to determine what their problem is. And the third is to educate and motivate the patient. Now, a differential diagnosis is a list of problems that could produce the patient's chief complaint. So when you're paged out for a patient who has chest pain, automatically you might think heart, but there are 65 different medical diagnoses for chest pain, and only a couple of them are heart-related. So, when I hear, hey, you've been dispatched to a patient who's having a heart attack, I don't assume that that's what's going on. I start thinking about all the different things, my differentials, that could cause chest-related pain, heart-related, or that could cause chest pain, period. Doesn't necessarily have to mean that it's heart-related. So initially, you want to consider as many differentials as possible when you first learn about the patient's chief complaint. And what this does is it prevents you from, getting tunnel vision. Even if you know the patient history, if you've gone to this patient's home because they're crying wolf and say that they have chest pain and it never turns out to be anything, you can't make the assumption that if they call for chest pain this time that it's not serious. So get as many possible differentials out there to begin with, and then as you obtain your sample history and your OPQRST, you're able to rule some of those differentials out and make decisions to say, well, it's not this, and it possibly could be this. And that's going to drive your treatment as well. So how do you begin that interview? How do you begin obtaining that comprehensive health history? Well, it's got to start first with an introduction. And during your introduction, you're introducing yourself, who you are, what your role is, but you're also obtaining the patient's name. They say that certainly, there's not a sweeter sound in the world than hearing your own name. And so it's important that we obtain the name of the patient and that we use it. We should avoid, terms of endearment like bud or honey or pal, because some people may find that offensive. And then during the interview, we're going to prioritize our needs. Initially, our needs are, to do our initial assessment and determine if there's any life threats and go on from there. It's important that we use open-ended questions, as a general rule. Open-ended questions require your patient to describe what's going on so that you get a better idea of what the patient is feeling. As an example, if a patient has chest pain, if you say, is the chest pain sharp or dull, that's not a very open-ended question. Closed-ended questions have limited choices, and the answers are either yes or no. Where an open-ended question for a person having chest pain might be, describe your discomfort for us. And then that way, the patient in their own words would tell you how they're feeling. You want to gather some demographic data. That's certainly not things we focus on. We're trying to figure out what's wrong with the patient, but demographic data is important on the back end when we start looking at, statistical information and filling out a patient care report. So obtaining things like their name, their address, the date and time, their age, sex, their race, their occupation, their place of birth. When you start talking about things like occupation, place of birth, their birth date, those sort of things, those are questions that can tell you a lot about your patient's mentation. Also, understanding who called you. If you're being called to the home for a patient having a stroke, a caregiver may have called you, a spouse or a significant other may have called you. Same thing like the scene of a motor vehicle collision. Rarely does the patient dial 911. And the point I'm trying to get across here is that when you arrive on scene, don't make the assumption that the patient, one, is glad to see you, or that they even requested your presence. That's something that you have to establish early when obtaining consent. Determine the source of history as well. You need to record who gave you this information. If the source was directly from the patient, was the patient alert, awake, and oriented enough to make that call? Or did you have to get the information from a caregiver or a friend? And the further out you get from the circle, the less reliable the information is. So finding out the source of the history certainly gives you a determinant of the value of the information. I've mentioned, how do we know the patient is reliable and that we can trust them, that they are in fact a good historian? And that begins with us determining what their mental status is. And we often will hear words like alert, awake, and oriented, AAO times 3. I've heard alert, awake, and oriented, AAO times 4. But a person can be alert and awake, or I should take that back. A person can be awake, but it doesn't mean they're oriented. They can be alert. Their eyes can be open, but it doesn't mean they're oriented. So determining their mental status is not only are they alert and awake, but are they oriented? We all should know who we are, where we are, a general idea of time, and what happened. Also, as far as reliability, you're relying on the patient's memory as to what medications they take and the doses of those medications. And certainly if they, if they have trouble remembering things because of a medical condition, or a physiologic problem like a low blood pressure, hypoxia, low blood glucose, then their memory is not going to be good, and the information that you obtain may not be, again, reliable. Trust is something, too, that determines the reliability of the information. If you haven't established a good rapport with your patient, they're not likely to they're not likely to spill their guts and let you know everything that's going on with them. So, obtaining or getting the patient's trust and gaining their rapport helps get additional information from them that is reliable. And then patients have to be motivated at times to give you that information, particularly if they don't believe that, one, you need that information, or that it's any of your business. It may be difficult to motivate them to give you the information that you need. It's important, too, that you document the reasons why the patient is unreliable, or why you believe that the information is skeptical. When we think about the chief complaint, that's what's wrong with the patient, and we want to record that in their exact words. That's important to us, that we record it that way. If we report it in our own words, we may actually put words in the patient's mouth that they didn't mean. So it's important that when we do record their chief complaint, that we record it in their own words. We've all been taught to obtain a history of the present illness if you're dealing with a patient who's ill. And this sort of follows along with the OPQRST, where you're talking about location, quality, severity, timing, in what setting is the illness occurring, do they have any modifying risk factors, associated symptoms or symptoms that you would expect to see with a particular illness. But I think what we are most comfortable with and should be is the use of the OPQRST, and I add the N on the end of that. N is normal. If you're dealing with a chief complaint of chest pain, one of the questions you might ask is, do you normally have chest pain? And if so, would the doctor say it was? That gives you an idea, too, of what may be going on. Onset is what you were doing when it came on. What brought this chief complaint on? Provocation or palliation is, what makes it better, what makes it worse. Quality is having them describe the discomfort. Certainly not putting words in their mouth with responses like, is your pain sharp or dull? When I do that, I not only give them two choices, but I also limit their response, in that if their pain is not sharp or dull, they've got to figure out which one of those descriptors fit it, and they may pick one that really doesn't represent the discomfort that they're having at all. R is region or radiation. Does the pain radiate anywhere? S is severity on a 0 to 10 scale, with 0 being no pain, 10 being the worst. Give that pain a number. And that's important as far as severity goes, because that tells us their perception of how intense this discomfort is. And then as we provide treatment, we should see an improvement in that discomfort. And then timing is, how long have you had that? Some other things to consider in obtaining a comprehensive history is to look at their past medical history. Now, I know that we like to get pertinent past medical history in the sampler, medical history that's pertinent to the patient's chief complaint. But if we've got, as an example, a person who we suspect is perhaps has shingles, it would be important to know if they ever had chickenpox, because that would confirm that perhaps what you're seeing is shingles. We want to know about adult illnesses, particularly if they have 2 or more, if they've got diabetes and COPD, or heart failure and COPD. Those are going to be exacerbated by any sort of infection or that sort of thing. We want to know if they have any psychiatric illnesses, if they've suffered any accidents or injuries, if they had any recent surgeries or recent hospitalizations. Recent hospitalizations are really important, particularly when dealing with patients who have asthma. if they can tell you that in the last 6 months they've been hospitalized and put on a ventilator and they're calling 911 because their asthma is really bad, chances are they're going to be hospitalized and put on a ventilator again. Their current health status. We want to know what current medications they're taking, because certainly meds that we may give, we don't want to counteract with what they're already taking. They may be taking meds that counteract with each other and may explain their chief complaint. We want to know if they have any allergies, again, because we're going to be giving meds. Certainly things like tobacco use, alcohol and drug-related use are important to know. What's their diet like? Do they have any dietary problems like celiac disease or Crohn's or colitis, or things that are inflamed by certain types of food? Are they allergic to any foods? And then, have they had any screening tests lately? Do they know what their sodium and potassium normally is? Do they know what their cholesterol normally is? Do they know what their blood pressure normally is? And then are they up to date on their immunizations? Some other things to look at in their current health status include sleep patterns, whether they're insomniacs or just drowsy. What's their exercise level? What do they do for leisure activities? If they're pretty much a couch potato, and that may go along certainly with some of the conditions that you're dealing with as well. And then, are they exposed to any environmental hazards on a regular basis when they do work? Are they chronically exposed to, grain dust? Are they chronically exposed to secondhand smoke? Are they chronically exposed to other environmental hazards, asbestos, whatever? Because those may explain some of their current health problems as well. What have they used for safety equipment? And if they did not use the safety equipment, this might be one of those teachable moments. You can also use sampler, where signs and symptoms are the current signs and symptoms that you're seeing based on their chief complaint. Are they allergic to medicines? Do they take any medicine or over-the-counter drugs? What's their pertinent past medical history? Last oral intake is important, certainly if we're thinking about diabetes or surgery or the possibility that their stomach is full. And particularly in those patients who are, maybe ate just a big meal and now they're having this exacerbation of their COPD and their SATs are low and they can't breathe and CPAP isn't working, and we're going to have to, put them down and, put them on a ventilator, that sort of stuff. It's important to know whether or not their belly's full. What sort of events happen prior to you showing up? And then the R in sampler is risk factors. Do they have any risk factors associated for what I may think is going on? If I think that this person is having a heart-related chest discomfort, do they have any risk factors for cardiovascular disease? Are they hypertensive? Do they take medications to lower their cholesterol? Are they heavy smokers, overweight, lead a sedentary lifestyle? All those sort of things can help us determine what the differential is. And then knowing or pinning down the differential is going to drive our treatment. In a comprehensive history, usually not, we get some of this, but certainly this is something more that you would obtain in an emergency department or something like that, where you're finding out their family history. Do they have any past history in their family of these problems, like alcoholism or anemia or arthritis or cancer or diabetes or drug addiction or epilepsy, headaches, those sort of things. And then heart disease, high blood pressure, kidney disease, mental illness, stroke, tuberculosis. These are just all questions that you could ask, because if they, certainly have a family history of diabetes and you suspect that they might be diabetic, you can put two and two together. Obtaining their psychosocial history is important as well. You want to find out about their home situation. Do they have a significant other that lives with them? And this helps you establish what sort of support systems they have. If they're a shut-in, live alone, nobody comes to see them, family does once a month or something, then their home situation isn't very good. And perhaps one of the reasons you've been called is that they're not eating adequately and they're not taking their meds on a regular basis, and you'd be able to point social services in that direction. It's important to know what their daily activities are, and are they able to function independently, because again, at a certain age, if this is the first time you're called into the home because a neighbor hadn't seen them for a few days and you find them in bed and you want to find out what their normal daily activities of daily living are. And are they really limited in getting around? Are they limited in being able to cook? Are they limited in being able to take their medications or even get their medications? Um, it's also good to know if recently they've had any major life changes, whether it be the death of a spouse or significant other, the death of a child, a layoff from work, foreclosure on the home. All these things are major stressors that we know stress, for one, lowers the immune system and opens you up to other illnesses. Um, you know, Certainly if you want to obtain their religious beliefs, that's important when we're dealing with particular religious groups that may or may not want things like intravenous fluids, that may not want things like medications, particularly given through an IV, may not want whole blood products administered, those sort of things. And then it's important to, get the patient's outlook or perception on how they feel they're doing, to help pick up things like perhaps depression or other psychiatric conditions. Now, another part of a comprehensive history is to ask questions, because remember, we're obtaining a history. This isn't a physical exam, but certainly reviewing systems. Do they have any issues with their diet? How has their skin and hair and nails been? Any issues with their head, headaches, earaches, dry eyes, stuffy noses, sore throats, stiff necks? Are they having, any trouble breathing, any irregular heartbeats or palpitations? How's their stomach been? Have they thrown up or diarrhea? Those sort of things. Frequent urination, difficulty urinating. Male, you want to check or ask questions certainly about their genitalia, to include, recent testicular exams or that sort of stuff. Female genitalia, when was their last menstrual period? Are they still in menses? If not, are they in menopause? Their obstetric history certainly is important as well. Have they had pregnancies, and if so, how many of those are actual children? Because certainly they can have miscarriages and those sort of things. And then breasts. There's breast pain, breast soreness, enlargement. The potential for when was your last mammogram, that sort of thing. Reviewing their peripheral vascular system, blood supply to their lower legs, and leg cramps and things that would indicate perhaps some vascular disease. Check ask them questions about their musculoskeletal system, any muscle weakness or muscle pain, or if they have any history of brittle bone disease or any of those sort of things. Their neurologic history, you're looking for, if you have any seizures, you have recent headaches, migraines, double vision, blurred vision, those sort of things, feeling dizzy, lightheaded. Hematologic, you're asking them questions here about their blood counts, if they're aware of it. Are they anemic? Endocrine, you're asking questions about certainly things like their metabolism, which is a reflection of their thyroid glands, their energy level, those sort of things, all reflection of their thyroid glands. Are they diabetic, which is certainly their pancreas, which is an endocrine gland, and then reviewing their psychiatric history as well. When we think about kids, some of the things that certainly are challenging when trying to obtain a comprehensive history on children is that, one, they may not be able to answer the questions for us, and the caregivers must have to answer the questions for them, as well as the additional questions about, their birth history. Was it a normal birth? Was it a cord around the neck, lots of D cells, and long periods of maybe even apnea? What the prenatal history was like? Did the mother have any delivery problems or any neonatal problems? The difference between a comprehensive history and a targeted history is often where you're at. In a hospital, we have the time to do comprehensive histories. In the field, we don't have time to do a comprehensive history. We just do a targeted history. Remember that when doing histories that you're going to get some pretty sensitive information about the patient and their medical conditions, and that information should remain confidential. That is protected healthcare information. That certainly is a HIPAA violation if that's shared, and in most cases can be the grounds for immediate dismissal from wherever you work if you violate HIPAA. When it comes to adolescents, young adults, most states allow the treatment of young adults without consent of the parent, particularly if we're talking about emancipated minors or we're talking about females that are pregnant. But it's important that we encourage, we know you don't have to tell your parents about this, but we believe that you should have that open dialogue with your family because they're there to help. So in summary, the medical interview is designed to gather information about the patient's past and their present and their medical conditions, establish rapport with the patients, and it requires techniques of active listening, letting the patient know that you hear them by shaking your head, by saying yes, by paraphrasing. And then it's important that we know when it is appropriate to use open-ended questions versus direct questions or closed questions in order to obtain an accurate history. If I've got a patient who's extremely short of breath and is speaking in 1 or 2 word sentences, I can't ask them lots of questions. Certainly the questions I ask them have to have a yes or no answer or a nod of the head answer. Understand the components of a comprehensive medical history, including the chief complaint, the history of present illness, the past medical history, the current health status, reviewing all the systems, not a physical exam, but just a questioning of all the systems. And that pretty much a real comprehensive medical history occurs in the hospital if you're a hospital-based employee, and ours is more targeted with sample OPQRST. Recognize that there are special challenges in obtaining the medical histories when dealing with a variety of patients. The elderly may not be forthcoming with their information because they may not trust you. Children may not be able to answer those questions. And certainly children in the presence of their adults may not want to answer certain questions. So separating the caregiver so that you can get a good history from that, prepubescent child or the teenager or the adolescent. All right. So that ends Chapter 16, and should you have any questions, you've got my email address as well as my cell phone number, so feel free to give me a shout. And with that, I'll talk to you later.